Dysmenorrhea, pain with menstruation. Dysmenorrhea affects over 50% of menstruating individuals. But when is period pain normal, and when is it a sign of pathology? This comprehensive review is designed for medical students, clinicians, and patients, covering all high-yield exam facts and real-life management. Dysmenorrhea is defined as painful menstruation that interferes with daily activities. It is classified into two major types. Primary dysmenorrhea, painful menstruation without pelvic pathology. Secondary dysmenorrhea, menstrual pain caused by an identifiable pelvic abnormality like endometriosis or fibroids. Pathology. In primary dysmenorrhea, excess endometrial prostaglandin F2 alpha increases uterine contractility and vasoconstriction, right pointing arrow, resulting in ischemic pain. In secondary dysmenorrhea, the mechanism depends on the underlying disease, like inflammation in endometriosis or mechanical distortion in fibroids.
Clinical presentation. Symptoms include nausea, vomiting, fatigue, diarrhea, headache, radiating pain to the lower back or thighs. Secondary causes. Secondary dysmenorrhea is usually more severe, starts later in life, and worsens over time. Common causes include endometriosis, ectopic endometrial tissue causing cyclical pain; adenomyosis, endometrial glands within the myometrium; uterine fibroids, benign smooth muscle tumors; pelvic inflammatory disease, PID, infection-related pain; congenital anomalies, like transverse vaginal septum or imperforate hymen.
Diagnosis. Diagnosis of dysmenorrhea begins with a detailed history and menstrual diary. Physical exam may reveal uterine tenderness or pelvic mass in secondary cases. Investigations include pelvic ultrasound to detect fibroids, cysts, anatomical abnormalities; MRI for adenomyosis or deep endometriosis; laparoscopy, gold standard for endometriosis; STI screening, if PID suspected; CBC, ESR, CRP, if systemic signs present.
Management. First-line treatment of primary dysmenorrhea includes NSAIDs. Examples are ibuprofen, mefenamic acid, inhibit prostaglandin synthesis; hormonal contraceptives, suppress ovulation and reduce endometrial proliferation; lifestyle changes, physical activity, dietary adjustments, stress reduction; heat therapy, effective adjunct. Living with dysmenorrhea. Untreated pain can lead to missed school or work, poor sleep, and even depression. But early treatment can restore quality of life and even fertility.
A 16-year-old girl presents with cramping pelvic pain that begins on the first day of her period and lasts for 2 days. Her periods are regular. She has no sexual history and no abnormal bleeding or discharge. Physical exam is unremarkable. What is the best initial treatment? A. Laparoscopy. B. NSAIDs. C. Oral contraceptive pills. D. Antibiotics. E. GnRH agonists. Explanation. First-line treatment for primary dysmenorrhea is NSAIDs, e.g. ibuprofen, mefenamic acid, which reduce prostaglandin production.
A 27-year-old woman reports worsening pelvic pain during menstruation and pain during intercourse. Her symptoms have progressed over the past year. Pelvic exam reveals tender nodularity in the posterior fornix. Which of the following is the most definitive diagnostic tool for this patient? A. MRI pelvis. B. Pelvic ultrasound, circa court abdomen and pelvis. D. Laparoscopy E. California 125 level. Explanation: laparoscopy is the gold standard for diagnosing endometriosis, allowing both visualization and biopsy.
A 22-year-old woman presents with lower abdominal pain that worsens during menstruation. She also reports abnormal vaginal discharge and pain during intercourse. On exam, she has cervical motion tenderness. Which of the following is the most appropriate treatment? A. Metronidazole alone. B. NSAIDs and observation. C. Doxycycline plus ceftriaxone. D. Hormonal IUD insertion. E. Endometrial ablation. Explanation: elevated prolactin with amenorrhea and galactorrhea raises suspicion for a pituitary prolactinoma. Imaging is necessary to rule out a mass.
A 35-year-old woman has heavy, painful periods and a feeling of pelvic pressure. Her uterus is enlarged and irregular on bimanual exam. What is the most likely diagnosis? A. Endometriosis. B. Adenomyosis. C. Uterine fibroids. D. Ovarian torsion. E. Polycystic ovarian syndrome, PCOS. Explanation: uterine fibroids, leiomyomas, often cause secondary dysmenorrhea with an enlarged, irregularly shaped uterus and heavy bleeding.
A 40-year-old multiparous woman complains of progressively worsening menstrual cramps and heavy bleeding for the past year. Her uterus is symmetrically enlarged and tender on exam. Which of the following is the most likely diagnosis? A. Uterine fibroids. B. Endometrial cancer. C. Adenomyosis. D. Ectopic pregnancy. E. Functional ovarian cyst. Explanation: adenomyosis presents with dysmenorrhea plus menorrhagia in women greater than 35 with a globular, uniformly enlarged uterus.
Final message: don't normalize pain. Dysmenorrhea is real and treatable. Share this video, comment your experience, and help break the silence around menstrual pain.